Good morning and welcome to The Doctor Is In, Ask Dr. Arwady. Today, I think, is it Tuesday?
It's Tuesday.
Okay, Tuesday, April 14th. We're glad that you're with us. I'm Sybil Madison, the Deputy Mayor for Education and Human Services. I'm here with Dr. Allison Arwady.
Good morning.
Our Commissioner for the Chicago Department of Public Health. If you have questions, comments for us, please put them in the comment box below. You can also send them through Facebook or Twitter using the hashtag AskDrArwady. We're going to check our social distance for any essential worker who's working right now. That is an important thing to do at all times. And also anybody who's just outside of the house, just making sure that you keep that 6 feet of distance between you and another person.
That's a good way, if you missed some of our earlier conversation about this, your wingspan from tip of your finger to tip of your finger is approximately how tall you are. And so if you sort of make sure you're at least that distance apart from each other, you'll be in the 6 foot range.
Yeah. So if you have to be in a conference room, which sometimes I find myself, I'm just like rotating, like, okay. So anyway, we're glad that you're with us. We always start off with an update from Dr. Arwady on the latest with COVID-19 here in Chicago.
Sounds good. So first of all, as always, I encourage you to go to chicago.gov/coronavirus. Right up at the top, you can see a tab that says latest data. And if you haven't looked at it in a little while, we've been doing a lot of updates. In particular, you can go and see updated maps. We've been doing those 3 times a week. So a batch went up yesterday that show where we're seeing cases across the city, both case counts by zip code, as well as the case rates where we correct for population, like we've talked about in the past. We also did our once weekly update of testing, both counts, again, by zip code across the city and testing rates. So it's a way, we really want you to follow along with us, what we're seeing in terms of our data locally. We obviously continue to push testing towards locations where it is most needed. That's been a really push from the beginning. But you can really see some increase in testing and just learn more about what we're seeing in that geography. Similarly, every single day, we do update our sheets here that have our lots of detailed demographic information. You can see in the city of Chicago, how do cases fall out among different age groups? How do race and ethnicity play out for our cases? What does gender look like for the cases? You can see data on related to deaths, our underlying conditions data, again, the specifics of age and gender and race ethnicity. So we update it every day. I encourage you to download it. We try to make the data as available as we can. And so if you haven't been enticed already to pull it up with me advertising it for 2 minutes. So here in Chicago, we are at 9,113 cases of COVID-19 and 308 deaths among Chicago residents. That was an increase of 529 cases and 31 deaths since yesterday. And Chicago numbers overall, that 9,000 or so cases, is about 41% of the cases in Illinois, which now stand at 22,025, and our deaths stand at about 38%. So 308 deaths in Chicago residents among the 794 deaths that we've seen, unfortunately, here in Illinois. So let's look at our graphs. These, again, we update every day. The first one just shows you the testing date for any positive test that has come in. That's why on the right side of the graph it looks like maybe it's falling off a little bit, but as you see in the words there, it doesn't reflect some pending tests. It hasn't caught up yet. We know that there are tests still that take a day or 2 or even longer to come back, and so we put them in the graph here by the date that the person was tested, because of course that's the date that actually matters, as opposed to when it was reported to us. And then if we look at the next graph, this is just our cumulative cases, meaning you put all the cases together and you see what the curve looks like. And I'm going to go ahead and do a preview. We'll remind you at the end, but tomorrow is going to be a big day for us to be releasing more data about Chicago here. So, we've been talking a lot about how really every day we're adding additional data, but we're going to have a dedicated press conference at 1 o'clock, and then we're actually going to move our Facebook Live tomorrow to 3 o'clock Central Time.
So we can unpack.
So we can unpack it. So just like we did for the first time we had the maps, and the first time we were looking at case rates, and we were looking at a lot of our more detailed demographic data, we really dove in there. We're going to do the same thing tomorrow, but at 3 o'clock after the press conference. So I encourage you to tune in then. We'll be talking a lot more about our curves. We'll be talking about some more about how our hospital system's doing, and additional information that will, I'm sure, be interesting to you. So I think just taking a second just to see if anything's changed broadly in our data. If we look at our case characteristics for Chicago residents, we continue to see cases absolutely across all age groups, fairly evenly distributed actually among the age groups. So, for example, our 50 to 59-year-olds are actually the highest percentage of our cases, and about 20%. Again, that would probably reflect more testing in that age group too, as compared to the younger people who are more likely to have asymptomatic or very mildly symptomatic infection. Children still remain just 1% of our total cases here in Chicago. And again, by and large, where we've had children who have been diagnosed, they've been almost incidentally found in a lot of cases where we've really been doing testing, and they've not had a whole lot of symptoms. In most cases, they've recovered. Of course, that's not a universal, and there can be people with underlying conditions, but that has continued to be reassuring broadly in the data. If we look at our case breakdown for men and women, it's about 50-50. And if we look at our breakdown for race ethnicity, just under 50% of our cases now are in Black non-Latinx Chicagoans, about 20% in Latinx Chicagoans, about 21% in white non-Latinx Chicagoans, about 4% in Asian non-Latinx, and about 6% in other. We still are missing data though, missing race ethnicity data for more than a quarter, even like 30% of those cases. So it's something we've been working on with providers. If you are getting a coronavirus test in Chicago, I would encourage you to make sure to, let your provider know. It's the law here in Chicago right now, that your race and ethnicity needs to be recorded if you're getting a COVID test, and then reported to the health department, because we just want to make sure as we track all of the testing, we're really paying a lot of attention to that. I think if we look at our deaths, as we've talked about in prior days, that's where we really see the fact that older Chicagoans in particular, similar to what we've seen around the world, just have worse outcomes. So we've talked about that people over 70 only represent 8% of Chicago, but they represent 15% of our cases and 58% of our deaths. So that's been around 58-60%. Really, if we look at all Chicagoans over 70 who have been diagnosed with COVID, about 13% have died, which means that 87% actually have not died, right? Have recovered. So even in those older groups, most people still don't die. But where you think about 13%, that is a really high mortality rate, a high death rate. Whereas if we compare that, if you look at in the 0 to 17 age group, the 18 to 29 age group, the 30 to 39 age group, the death rate is well under 1%. So much less than 1 in 100.
So it's a very large difference.
It's unusual. We do have cases. There have been 5 people, for example, in that 30 to 39 age group who have died, but it's much less likely. And then the rate, the risk really increases as we grow. So again, take a look online if you want to see this data. We continue to see more men, 58%. Die as compared to only 42% of the deaths being among women. So we've talked about that before. We can talk about it again someday if people have questions. And if we look at our race ethnicity data, 67% of our deaths right now are in that Black non-Latinx community. And so, continues to be a focus. 92% of our deaths, at least there's some still under investigation, have underlying conditions. So we see this, data fluctuate a little bit from day to day, but broadly, the same information, the same way that COVID has presented around the world is similar to how it's presenting today.
And I think worth repeating that those underlying conditions include diabetes, heart disease,
Yes.
and lung disease.
Yes, those are the top 3 here in Chicago, as they have been really in other settings. I've been doing a little bit of reading about how other countries actually report some of their cases, and there are some different ways that's been done. There's a lot of conversation about how to count cases. Certainly, we all know that we're going to count lab confirmed cases,
Yes.
but we know that there are people who have not been tested at this point, right? And we talked a lot over the last few days about how as antibody testing comes in and what that's going to look like. We'll probably have, because we have for every other disease, a confirmed case definition with a lab, and then a probable case definition where people have had symptoms, but perhaps not been tested, and we're trying to figure out what that looks like.
Is that still captured by healthcare providers versus self-reported?
It would be captured. Well, probably it'll be a mix of both, actually. I think in a typical outbreak, this would be healthcare providers. I think here, as increasingly there's going to be ability for Chicagoans themselves to keep track of some of their own symptoms, and we're going to have some more technology that's going to allow you to report that to the health department. That's coming. But I think we'll probably develop a probable case definition even out of that. It's a really active conversation in the U.S. But also, China, for example, it turns out really doesn't count asymptomatic cases in its case counts. And that is partly because, of course, early on, it wasn't really known that there were a lot of people who were asymptomatic. But I think some conversation about even just like internationally, how cases are counted.
Do you mean people who were tested tested positive but were asymptomatic?
That's right. That's right. Yeah, they've really not been counting them, at least in most cases. Among the cases, that may be changing at this point again as we're learning. But I mention it because it just gives a sense of how hard it is to very quickly ramp up sort of not just a local, but a state, national, international way of being able to track cases in a way that allows you to compare sort of across settings.
Yeah. There's so much that's being learned and done.
There is.
At a rapid pace here with this new virus.
Yeah. And we really, we've got a lot of partners working with us. I mean, there's partners, amazing people stepping up all over the city. We did yesterday a press conference about the work related to people who were unstably housed or experiencing homelessness, and just, amazing clinical partners and community-based partners, folks who have just absolutely stepped up to really work with this. But on the data front, in the same way, we've got partners. We've got researchers, we've got academic folks, we've got modelers, and all kinds of people who are really putting their minds into what our local data looks like here and how that fits into the larger picture. So it's been, it's a challenge, and we certainly are trying to move very fast on the data front, is in the same way that we're trying to move fast on testing and therapeutics and vaccines. But it's it's a challenge every day, and we're working on being as quick as we can to really, we want to be transparent with you, let you see what we're looking at as we're making decisions as a city and as a state about the big long-term questions.
Yes. And I want to give a shout out to Westside United for partnering with us on the work that we're doing to respond to the demographic data, the racial equity work.
Yep.
Okay, so shall we get into questions, Doctor? Our camera crew had a couple questions that were really good, and so we thought we'd share them with everybody. So one of our crew members asked, with summer coming and people kind of having their skin out more, is there any concern about the virus and getting into your skin, especially if you get cut or you have, an open scratch or something?
Yeah, so it's a great question. I told them that yesterday too. Really the answer is no, not a concern. So there certainly are diseases that can get in through the skin or through a cut. Ebola was an example of one of those. And so if you remember back to the big outbreak in 2014 and 2015, we were having to have all kinds of just very, very careful protective gear and special ways of transporting, because even a small minuscule cut had the potential that the virus could get in. And so luckily this one is a respiratory virus, so it is spread in the same way way that influenza, colds, these respiratory viruses, broadly speaking, are, which means they have to get into your respiratory tract. It's internal. So it gets in, it doesn't get in through your bloodstream. It gets in through primarily your nose, your mouth, and potentially your eyes. And so that's why we talk so much about doing the hand washing and how the hand washing is important, especially because we very often, without realizing it, will touch our faces, our eyes, our nose, our mouth, and that is how the virus actually gets in. But yeah, not a concern for cuts or sort of sweating or having more skin out or anything like that, even as the weather warms up. Keep washing your hands, keep the social distancing, but not a concern.
Okay. Here's another one from the crew. Will the vaccine, and we talked a lot about the vaccine yesterday, about the work around the vaccine yesterday, will the vaccine be combined with the flu vaccine?
Yeah, and really I sincerely doubt it, at least not in the short term and probably not in the long term either. We did talk yesterday about how there's these different platforms for vaccines, different ways of both producing the vaccine and then also manufacturing it. And there's already, the work of creating a new influenza vaccine every year and then producing it at the scale that it needs to be produced and sort of doing that in one hemisphere of the world and then the other hemisphere of the world already is a really massive scientific undertaking and production. And it's very unlikely that the way the vaccine for COVID works will be the same as the way that the vaccine for flu works. And then it's doubly unlikely that you would have a manufacturing process that would sort of be able to take both of those in. The obvious, the work of getting a vaccine for this is going to take the highest priority, of course, and they won't want to slow anything down by combining viruses.
Yeah, that makes sense.
Yeah.
So 2 shots.
2 shots, yep. It's kind of like, if people remember back to 2009, 2010, that's when we had the H1N1. That was that other strain of influenza. And that year, there was a regular flu vaccine and then an H1N1 vaccine. And so this one isn't flu. It's the first time we've had actually a pandemic of a coronavirus. All of the pandemics this century, there have been 4, were all in various influenza vaccines. So this one is COVID, but nevertheless, the vaccine, I'm quite positive, will be a separate one. And there's still a lot of questions about whether you may need multiple doses of that, how long it will last. We talked about that yesterday.
Yes, we did. Okay. Jeff Berry from Twitter, what are the recommendations for people living with HIV and hashtag COVID-19? Are they the same for people living with HIV who are over 60?
Okay, yeah, great question. So the main question there would be, how well is your HIV controlled? I hope that your CD4 count is good and your viral load is low and that your HIV is in very good control. I think we would think of this as something, like a diabetes, where certainly HIV is an underlying condition that affects your immune system, and so you would be at higher risk for potentially severe complications from if you were to be infected with coronavirus. But in the same way that people with diabetes who their diabetes is not very well controlled would probably have worse outcomes than someone who has well-controlled diabetes. Maybe they just, they take a pill a couple of times a day and their sugar levels are good. In the same way that if you're on all of your appropriate medicines for HIV and in good control there, the risk would be probably not significantly more. But you should be careful, right? Like someone who has any underlying immune problem, not just HIV, but people who have some of the other autoimmune type diseases, or people who are on medications that work on the immune system, people who have, gotten an organ transplant, for example, people who may be getting treatment related to cancer that affects the immune system. All of these people would be considered at higher risk for having the more severe complications. And so those are the folks that we want being extra careful and really trying to take care of yourself. But HIV is like anything else. Just take your meds and be as on top of your underlying conditions as you can, and keep getting all the good things, the good sleep and the stress relief and the trying to eat the healthy foods and just be as healthy as we can would apply to anybody with any underlying condition.
Okay. Somewhat related question, Sean Smith from Facebook. There are people who think HIV meds, including PrEP, confer resistance or immunity to COVID-19?
Okay, good question. So the short answer is no. That HIV meds, including PrEP, pre-exposure prophylaxis, would not give resistance, would not give immunity. I think this is another example, perhaps, if people are hearing this rumor of where there's something that people hear that kind of gets twisted a little bit and then becomes part of this conversation. There's a medication that is sometimes used for HIV there have been some trials of people who have been seriously sick with COVID that they've been working to sort of see, again,
this is maybe where this
is coming from, that there's been some, it's an example of one of the many, many drugs that are in trials sort of around the world to see if they have some promise. HIV medications do modulate the immune system, but there's no evidence at this point, at least that I'm aware of, and I'll check back to make sure there's nothing I'm not caught up on there, but that there's certainly not a medication related to HIV that's been shown, to my knowledge, to have any effect here, and definitely not. You do not want to be changing your HIV medications. You do not want to be changing your PrEP if you take PrEP. Keep taking all of your prescribed medications in the way that they are prescribed for any underlying condition. And people who have HIV will know that it's especially important to take all of your medications as prescribed, because you can develop resistance if you are only taking some of your medications or sort of picking and choosing a little bit. And so, as always, take all the medications as prescribed. Don't take medications that were not prescribed to you just because you think that they would help in coronavirus, and take them at the doses that your doctor has suggested for you.
Okay. So that makes me think of this chloroquine.
Yeah.
That the president has talked about quite a bit.
Yeah.
What's the latest on that?
Yeah, so chloroquine is one of these drugs. It's really an older drug that was developed for malaria, and the hydroxychloroquine is a cousin of it, and it's one of the drugs that there is in studies, and that there is one of the areas that can.
So they're looking into it.
They're looking into it, but the thing is, we talked about, especially the hydroxychloroquine, right? This is a medication that people take for, again, immune conditions, and like lupus, for example, rheumatoid arthritis, et cetera. And where there's been some stockpiling and people inappropriately wanting to get this medication, there are people who need it to control their underlying conditions who have been having trouble getting it. But more to the point, like, these are strong medications, they can have negative side effects, and there have been some studies. We saw anecdotally that, if you remember, one of the first times we talked about chloroquine, there was a couple in Arizona who had tried to take what they thought was chloroquine, and it was something you would use in an aquarium, and one of them died, and one of them was in the ICU. Like, no, please no. But also, like, I was just reading the other day that one of the studies of chloroquine, specifically in Brazil, that when you do a randomized trial, you give a certain number of patients, you give them the drug, or you give them a different dose of the drug, and you follow and see what the effects are. You do all the appropriate things. And they had a couple arms, meaning a couple groups of patients, hospitalized patients with coronavirus, and they were giving them 2 different doses of chloroquine, and they had to stop the trial early because patients, especially in the group that were getting the higher dose of chloroquine, were having much more bad rhythms of their heart, and they actually had 11 patients die in a study that did not have very many people in it, of these heart problems with the higher dose of chloroquine. And so when you see that kind of safety problem, you actually stop the study and you say, no, right? Yeah. Like, certainly at this higher dose, there's real concerns about this. Obviously, when people are getting those medications, they're very sick to start with, right? Yeah. This isn't
and they've agreed to be a part
of it, and you don't know 100% sort of what caused what, but where you see that kind of difference, it just highlights that we really want to make sure that the appropriate scientific research is done around any of these treatments. Like, we should not be promoting them until we know that they're safe at what dose and that they work. So in the same, vaccines take a long time to do that. Medications, they don't take as long, but there is some time needed. I promise I will tell you, we follow this research really closely. When there is data available available on treatments that work for coronavirus, but there is not one yet that has been shown to be universally effective. And people who are seriously ill in the hospital, they're getting enrolled in these trials, including here in Chicago. They're getting medications, they're getting the appropriate monitoring that you need if you're getting those medications, like the heart monitoring,
they are getting
for example.
care.
They're getting care.
Even though we don't have a cure.
They're getting care even though we don't have a cure. But doing some of those trials so that we really understand what works is important. And there's a lot of really interesting, actually, trials going on. There's some drugs that are being developed that would be actually trying to give the antibodies themselves. This was an approach that was done with Ebola, the ZMapp drug, if people remember. So there are some researchers that are working to try to actually create the antibodies, right? It's not like a vaccine where it's long lasting, but perhaps for somebody who's seriously ill, it might have some effect, but we just don't know yet. And there's a lot of complications you have to
So you create the antibody outside of the body and you put it in the body to fight the virus.
That's the idea. And if you've heard, actually, I guess we can go down this track for 1 second because it's interesting. People who have recovered from coronavirus, again, we've talked about that you develop some antibodies. And so one of the very oldest treatments that we have related to infectious diseases is this idea that you take the blood of people who have recovered from a disease, recovered from a virus, and you try to
you transplant it?
Yeah, kind of. You separate out what's called the sera, which is a particular part of the blood that has these antibodies in it, and then you can try, it's experimental, but you actually try giving some of this sera to people who are really sick, and then you have to, in a study kind of way to see if it has an effect. So literally we've been doing this for 100 years probably, and there are studies for doing this for COVID, and so you may hear that there are blood banks. I think the Red Cross is even starting to potentially do some collection of some of this, but it's very early, right? Again, it's an experimental treatment that has some promise, but it's different than something that you would produce. So that's the sort of individual. You get the sera from a lot of people who have recovered, and you may be able to use it. Separately, there's work to try to develop antibodies based on, again, some of the genetic sequence that may be
we talked about that yesterday.
Exactly, that may be a way to have a treatment that, again, you'd sort of have to give through IV. It's expensive. It's not a sort of cure-all, but there's certainly work to understand, probably for people especially who are seriously ill. And then there's a lot of testing of existing medications, like some of the ones we've already talked about, and others,
and whether they have any kind
and
of
whether they
curative
have any kind of effect. And lots of scientists around the world working to develop all kinds of different approaches based on the proteins, based on the immune response, based on all sorts of different things. And we do have a lot of experience with trying to develop drugs, and so they're building on that where they can. But viruses tend to be a little harder than bacteria and other things to develop medications against. So anyway, lots of work there.
I know that you'd love to tell us why, but maybe we should go to another question.
Enough, sorry.
I could tell. Paula Greenup from Facebook. How is CDPH disseminating information to companies or employers about cases within or outside their organization? People who have survived are being ostracized when they return to work, when they return to work at places like clinics and nursing homes.
Okay, so those are sort of two different
questions.
But
how do you disseminate information about people who have been confirmed as having COVID?
Yep.
And then what do we do about folks who may have recovered from COVID, or maybe even people suspect that they have it?
Some of that stigma. So let's take those one at a time. So first, the question of who does the health department tell? So there are very, very strong privacy laws all the time around who is allowed to sort of know about somebody else's disease, right? You think about when you go to the doctor and you sign all kinds of privacy forms for HIPAA and others. Because we consider privacy a very important thing here. Around the world, but in the U.S. we really take it very seriously. And those privacy privacy concerns only grow when it's related to
Yes.
an infectious disease, particularly an infectious disease where there's the potential for a lot of community interest or stigma or anything around. So the health department, when we have a case, we communicate directly with that case. And then even if we're doing an investigation where we're needing to potentially contact others who may have been in contact, we actually don't use that person's name, for example. And this is the same for when we're investigating sexually transmitted infections or other types of infections, HIV, whatever it might be.
Just standard practice, the person is
Standard
anonymous.
practice. We keep the person's identity protected. We might let people know that there's a possibility they might have been exposed to coronavirus, and we would talk to them about places they'd been, folks, exposures that they may have had. But the health department will not release the identity of an individual, including to an employer. That said, certainly where there are settings where there are clusters of cases, we may do an investigation, again, in a way that protects the privacy of the individual. And so in the same way that we don't tell the owner of the apartment building where you might live, we don't tell people who call up and want to sort of know, we really do protect that individual data, but we use it to understand and investigate in appropriate ways where we do see clusters.
Yes.
We talk to healthcare providers, of course, about the patients that they diagnose, but there's, of course, privacy pieces that go around with that. And then we'll work with, because what we see happening a lot with this disease in particular is that people will self-report, right? Will report to their employer, and it's not a thing to be ashamed of in any way,
Yes.
right? If somebody has COVID, I want to be really clear about that. And there are reasons that you want to make sure the people around you are aware. And so I think if people are comfortable doing that, that's good and appropriate, and we want employers treating that data carefully and privately, and if they are doing notifications, for example, that there's been exposure, that should not name employees' names,
Yes.
And the health department regularly sort of consults in situations where that comes up. And then to the second part of the question about some of the stigma around recovered people, I mean, this is an age-old problem, I'll tell you. Like, when I worked on the Ebola vaccine, the Ebola outbreak, or like that MERS outbreak internationally, like we'd see this, people who had recovered from Ebola who, again, were really valuable because they were much safer to be helping take care of other Ebola
Yes.
patients for a very infectious disease that had a mortality rate that like 1 in 2 people infected would die, much higher than this.
Yeah.
But we had the same problem where people were scared and not wanting to let folks home. And we've heard stories, I want you to know, we've heard some really unfortunate stories here in Chicago of healthcare workers being harassed, being told, get off the bus if they're wearing their...
Or not provided with services.
Not provided with services. We heard a story about a nurse who was in a parking lot and, called for the car service, and they wouldn't come sort of help with her car because they heard she was a healthcare worker. Or we heard about a technician who was, wearing a badge or something and was shopping in, at a store, and another, someone in Chicago really started yelling at them for being out. And it's really not acceptable. Obviously, like the people who are working in healthcare settings, the people who are essential workers of all kinds and are needing to be out, are really, putting the community's needs before their own. And most people have been very supportive, of course, of healthcare workers, but you don't, if you're keeping your social distancing from someone, if you're doing all your appropriate hand hygiene, there is no reason to be inappropriately targeting healthcare workers or anybody else, discriminating, right, against people for race or ethnicity. We talked about that with Asian descent, for example, earlier on, or against people for the work that they're doing. And so we are actually a little bit in response to this. The city has been putting together some resources about specifically how we're supporting healthcare workers. There's a little microsite within the main website that is really letting healthcare workers know there are free sort of group and individual counseling available. There, of course, are lots of discounts and free services, and thinking about all of our essential workers, but really some of the specific needs of healthcare workers. So if someone is not appropriate to be thinking, and if somebody has recovered from coronavirus, we've talked about if they've stayed home that 7 days and at least the 3 days, they've recovered from it. You don't have to be scared of people. It's great. They've recovered. They're back.
Yes.
And please treat them as you would anybody else in an appropriately socially distanced way.
Yes. Yeah. Okay. Eleni Lanzarakis from Facebook. If a nursing home employee has been diagnosed with COVID-19, but was not on a floor that your loved one is on, how likely is it that someone will get it on the other floors?
So that's a really good question and a hard question. Certainly when, one of the settings where Chicago Department of Public Health does a lot of work are in all of our long-term care facilities. That's our nursing homes and other places where a lot of really vulnerable people who tend to be older, who tend to have underlying conditions, are all living in their home, but together and interacting with each other in a shared space, and where they need a lot of hands-on care, especially. You think about people who may have, dementia or other, or just a lot of physical needs. The risk for spread is significant in those settings. And so I'm guessing what this is referring to is where cases are identified, and we've had them identified in just dozens and dozens of these facilities already. We work very aggressively, both proactively and responsively with the facilities, and we'll look at things like where, can you do some cohorting, it's called, of either people who have been infected or maybe exposed. If you know about a healthcare worker, where has that healthcare worker worked? Make sure that you're doing testing in that setting. And you may do some of this sort of floor by floor or area by area, really trying to keep parts of the facility sort of segregated and as safe as we can. But it's complicated for sure. And so it's one of the reasons why, the health department has worked to make sure that all of the long-term care facilities, have gotten PPE, for example. We want healthcare workers, obviously, if they're sick, they cannot be in there, right? Visitors are really not being allowed. There's a lot of that kind of stuff to keep it out, but also really that universal masking in healthcare settings. Same for hospitals, same for long-term care. That's mostly about if a healthcare worker were in that asymptomatic phase and potentially having the potential to transmit. But so I would say, if it sounds like this may be somebody's specific situation, I would be in touch, I'm sure you are, with the facility, really having some understanding of what the facility has put in place. But thinking about floors and different parts is a big part of this conversation. The other thing that I would say, we mentioned this the other day, but I think it bears repeating, is that we know that for the great majority of families, when they have loved ones who are needing to be in especially a nursing home type care, it's because they have care needs that just are above and beyond sort of what people can do at home, and we totally understand that. But where we think about any potential way to reduce risk in these congregate settings, if there are, if you have loved ones who are living potentially just in senior housing, maybe without needing as much of that hands-on type care. They're fairly independent. Or we do recognize that there are people who may be home themselves because unfortunately they're out of work or they're working from home, may have more potential to maybe care in a temporary kind of way for an older family member. If there is the possibility to remove folks from these higher risk settings, that's a good thing. We know that it's not possible for the great majority of families, but I just think it's worth mentioning in case that's a possibility. And for people who are in those settings, obviously the facilities are taking a lot of precautions. They're doing what they can. And people in those more senior settings, I know already you're not all gathering together to be eating, and it's hard, right? Like that. Often that's part of why people are in those settings. And if you're just in your apartment and you're not going out, it's fine. But just recognize recognizing that if you've got more vulnerable family members and there is any possibility to remove them from a congregate setting, that could be a good idea. Assuming, of course, that you don't have, a healthcare worker at home who could expose them or other vulnerable people. So it's not a straightforward decision at all, but it is something to consider.
Okay. Cynthia Regina from Facebook, do you think wearing masks in public, that is on public transport, in grocery stores, etc., should be mandatory in Chicago as some other cities are doing?
Yeah, so, and actually I saw it yesterday, a few people were commenting that we weren't wearing masks, so let's talk about that again. Really the recommendation for that face covering, if you look at it from the CDC here in Chicago, etc., is particularly for settings where you're not able to maintain that 6-foot social distancing. So we think about, and I in fact put masks on, put face coverings on, I have a cloth face covering, where I'm going into a pharmacy, going into a grocery store, maybe in a setting where there may be some more crowds. I mean, we're very conscious of trying to keep that distance, but if we're sitting here, we have our appropriate social distancing, it's a controlled environment. Again, that face covering is mostly about my germs not getting out, not getting
protecting others.
Yeah, not getting to civil. In the chance that I had an early stage of coronavirus and we're not having symptoms, that would help really protect. But so in terms of it being mandatory, it's not something that we have that we're planning on at this point here. Obviously, data continues to emerge about these, but it's really clear that the face covering is pretty low in the order of the things of priority. And you've heard me say before that I do have some concerns that if people are wearing face coverings, there's a feeling like I'm protected, and I've seen it myself. They get closer, they touch, some people can just touch their masks a lot, which is
it's uncomfortable.
And then that's getting your hands onto your eyes, nose, mouth, maybe without the hand hygiene. So there is a space for them, there is a role for them, but I think that it is most appropriate for people to be wearing them in settings where they're not able to control it, and really think about not having that face covering replace the more important social distancing and hand hygiene roles.
And it's worth repeating, if you are having symptoms, you should not be outside.
It is the law in Chicago, and it's been the law since before even Illinois shelter-in-place went live. If you go to orders, the tab up on the website there, you'll see the very first order we did was that order requiring that if you have new onset of any of these symptoms, if you're sick, even a little bit sick, you must stay home.
Right, including sore throat and congestion.
And body aches and unusual fatigue, as well as the more common fever, shortness of breath, or cough. We really wanted to emphasize, because we learned early on that there were people who could say, Thursday was the day that I really got sick, but there were a couple days before that they had started to have symptoms. We know there can be spread very early on, more than we've seen with a lot of other viruses. And we also know now that there are people who don't develop symptoms at all who have the potential to spread. And so those are the settings where even a little bit sick, home, and then that cloth face covering is part of keeping your germs from spreading to others if you are not having symptoms.
Yeah, I just wanted to re-emphasize that, because the only people who are walking around outside should be the people who do not have symptoms, right?
Yes, that's right.
And taking care of essential tasks.
Taking care of essential tasks
jobs.
Or essential workers, exactly, for sure.
All right, well, we got the cue that it's time to wrap things up. We do want people to know that Chicago's Business Affairs and Consumer Protection Office is having a webinar today. Workers' rights came up in one of our questions, and that webinar is being offered today, a focus on workers' rights. It's at 2 p.m. today. There's one in Spanish on Thursday, also at 2 p.m. You can go to the website, the Business Affairs and Consumer Protection website, to register for either of those webinars.
And I will just add that I think probably later in the week we're going to bring in someone from Chicago's Department of Family and Support Services to give some more detail into the work that we're happening to really support families and support people who, for example, don't have stable housing. So start thinking about those questions. It'll be a couple days off, but start thinking about it. And we got a nice one in here that there are nearly a dozen South Side organizations who have partnered to provide free activity bags for students every week while kids are unable to attend classes. And so there are age-appropriate bags for kindergartners through 8th graders. They come with free books and coloring materials and puzzles and crafting. So you can go to covidyouthreliefbags@gmail.com or email them.
That's wonderful.
covidyouthreliefbags@gmail.com, or you can call 312-983-2655, and they're apparently delivering bags every Friday until schools reopen. So especially if you're on the South Side, email, reach out if you've got kids and you're trying to figure out what to do with them.
Yeah, they're coming in handy.
They're coming in real handy right now.
Okay, so we'll be back tomorrow. Again, there's going to be a very important press conference at 1 with the mayor and with the commissioner sharing some new data with Chicago, and then we'll be on at 3 to dive a little deeper into those data and what they mean.
Yep. Have a great day, everybody. Stay home. Save lives.
Oh my God.